All right. So welcome everyone, and we're really excited to have Harper present some cases and look forward to some interesting discussion. So Harper, you can share your screen and we'll go from there.
Hello, does anyone see my slides?
Yes, look great.
Yes.
Thank you. So I'll start. So we'll start with some low power view pictures. You can see that there is certainly a lesion. Sorry, I'm just gonna laser pointer. Okay, so we certainly see a lesion there that is almost completely replacing the dermis and infiltrating the subcutaneous fat, which we'll take a closer look at. It's still low power view, but can anyone help me describe the pattern of the subcutaneous fat infiltration here?
Well, it looks like it's sort of infiltrating around and through the fat, but still
Yes,
preserving some of it.
yes, that is correct. So, like Dr. Hassel said, it infiltrates the fat, but there's still some preserved fat in and around it, and it forms this sort of like a honeycomb pattern that is characteristic of this specific lesion. Another low power view, we can see that our epidermis here is spared from the lesion. So the lesion does not infiltrate our epidermis, and it's in kind of like a thinned atrophic epidermis. This is a closer look at the epidermis itself. We can see the difference here. There is some loss of red ridges. And like I said, the lesion is sparing the epidermis itself, and it's a little atrophic. This is a closer look at the structure of the tumor itself, the pattern, and you can see what I told you about the honeycomb pattern. And we'll on the next slide we'll take an even closer look at the morphology of the lesion. So can anyone help me describe what morphology or pattern can be seen in here?
It look like a swirl shape.
Yes, yes. So it's arranged in sort of like a fascicular, almost like a tight story-form pattern. So we have a lesion that is almost completely replacing the dermis, but sparing the epidermis, an atrophic one at that. And the tumor invades the subcutaneous fat in a honeycomb pattern. And the morphology of the tumor itself is fascicular to a tight story-form pattern. So, can you make any guesses on what kind of lesion this is? Okay, so I'll reveal the answer. So today we'll be talking about dermatofibrosarcoma protuberans, which will start with the epidemiology. Um, Dermatofibrosarcoma protuberans, or what I'll be calling from here DFSP, is a superficial, locally aggressive fibroblastic neoplasm having a cellular storiform appearance and carrying a COL1A1 PDGFB or related fusion. It mostly occurs between the ages of 20 to 50 years old, although it can occur at any age from infancy up to 90 years old. There is no strong predilection between male or female. And for the site that it usually occurs in, for the trunk, especially chest and shoulders, it's 40 to 50% of cases. Proximal limbs occurs on arms more than legs, 30 to 40%. It also occurs on head and neck, especially the scalp, cheek, and supraclavicular area, which is 10 to 15%. And acral sites are uncommon, although there have been around 9% of it in pediatric DFSP. For clinical presentation, it presents itself in two stages. For the first stage, it is called the early or the plaque stage. As you can see in this picture, it is a firm, asymptomatic indurated plaque. It can appear reddish, violaceous, brown, or skin colored. It is fixed to the overlying skin, but usually not going into the deep structures. At this stage, it can be misdiagnosed as scar, morphea, morphea-form basal cell carcinoma, atrophoderma, or vascular malformation. And then the next stage of what we called its name protuberant or nodular stage, it's a development of multiple firm nodules within the plaque, or we call protuberance. And sometimes it presents as a single firm cutaneous nodule. At this stage, it may be misdiagnosed as lipoma, sebaceous cyst, or dermatofibroma. And for the macroscopic or gross feature of this specific tumor, it may be gray, white, or firm, and it can also be myxoid or gelatinous depending on the subtype of the tumor itself. We'll get into the microscopic features of our classic or conventional DFSP. As you can see in our initial pictures and also here in picture A and B, there's a low power view of tumor cells almost completely replacing the dermis itself, but still sparing the epidermis, an atrophic one at that. And for image C, we can see the characteristic honeycomb pattern when it infiltrates the subcutaneous fat and entraps the subcutaneous fat. D, we can see the interwoven fascicles of forming a tight storiform pattern. And this is the microscopic features of the conventional or classic DFSP. There are many histological subtypes of DFSP. I'll go through each of it briefly, but I will be focusing on a very important subtype at the end. So we have our classic DFSP. As we've learned, it has uniform spindle cells in a storiform pattern. It infiltrates the dermis in a honeycomb pattern, but there's minimal atypia and low mitosis. It is strongly and diffusely positive for CD34, which is an IHC that we can use to diagnose DFSP, but it is negative for factor 13A and negative for S100. We have our pigmented subtype. Bednar tumor, this term is no longer used in WHO, according to the WHO Blue Book, but we can call it pigmented DFSP. Same pattern as the classic DFSP, but with melanin-containing dendritic cells, so it may be focally positive for S100s in melanocytes. And then we have our what they call our pediatric DFSP, giant cell fibroblastoma. The term is different, but it's classified as a DFSP because it contains the same characteristic fusion as classic DFSP. It occurs in children. Usually it has a myxoid stroma and multinucleated cells, giant cells. The IHC is the same as classic DFSP. Same as atrophic DFSP, just with a thinner dermis. Sclerotic DFSP, it is more paucicellular, so less cellular than a classic one, and it contains dense collagenous and sclerotic areas, but it has the same IHC as our classic DFSP. Then we have a granular cell DFSP, which is a very rare variant with granular cells and lysosomal granules. So it is positive for the IHC of granular cells, which is NK1C3, but otherwise it is similar to our classic one. It may also differentiate into a myxoid or a myoid differentiation. And for a myxoid, of course, it has prominent myxoid stroma. Myoid, it contains a smooth muscle-like appearance, may be perivascular, and it can be positive for SMA and focally positive for CD34. And then here's the subtype that I wanted to focus on, which gives a worse prognosis for DFSP. It is a fibrosarcomatous DFSP, or what we call DFSP-FS. What's different from our classic DFSP is that its architecture has areas of high cellularity, and it's less of a story-form pattern and more of like a herringbone and more fascicular pattern. It has higher nuclear atypia, it has higher mitoses, less collagen, and often it doesn't exist by itself, but it coexists with a classic DFSP. So you can see an abrupt transition from a classic story form pattern and less cellular to a higher cellularity with herringbone and more fascicular pattern, and also moderate to high pleomorphism. And it's tricky in this case because in fibrosarcomatous differentiation, there is absence or loss of CD34. Positivity P53 is overly expressed, and there is increased Ki67. So we'll take a look at our fibrosarcomatous transformation here. You can see the difference in the low power view. It is more infiltrative than our classic one, so it is almost completely replacing the dermis itself. The pattern is also different in that it is more of a herringbone structure and less of a world story form structure like we've seen in our classic DFSP. The cells are high, mild to moderate pleomorphism, but certainly more pleomorphic than our classic one. And image D is just an example of a mysoid type of DSFP. So you can see abundant mysoid stroma here. We moving on to immunohistochemistry. So the definitive diagnosis of DSFP is usually established on the basis of histopathological and immunohistochemical features, although sometimes molecular pathology may help in some cases. As I've said, it is positive for CD34 in almost all cases of DFSP, so 80 to 100%, but maybe negative in 10 to 20% of cases in case of fibrosarcomatous areas. It's not entirely specific as a lot of mesenchymal tumor is also positive in CD34, and that's why if we cannot differentiate solely by morphology, molecular pathology is useful in such cases. It is negative for factor 13A, which is useful to differentiate between dermatofibroma, which is positive in factor 13A, but negative in CD34. Additional positive markers may be a polypoprotein and nestin, although these are not widely used. You can see in here our staining of CD34. In a classic DFSP, you can see that it is strongly and diffusely positive for CD34. This is a high power view, and you can see it clearly. But then we go into picture C, and you can see that there is areas where it is highly positive and areas where there is almost absence or low CD34, which is our fibrosarcomatous areas. And that is why this is tricky to diagnose. That's how diagnostic molecular pathology will play a role here. DFSP has a characteristic molecular translocation. I'm not trying to pronounce this, but yeah, this molecular translocation creates a COL1A1 PDGFB fusion, which causes PDGFB overexpression and drives tumor growth. This molecular translocation defines DFSP and explains imatinib sensitivity in unresectable or recurrent cases. So tumors that are positive for COL1A1 PDGFB fusion is sensitive to imatinib mesylate that can be used as a neoadjuvant therapy to help in difficult or unresectable cases, which we'll discuss later in our treatment. Giant cell fibroblastoma, as I've explained at the start, it shares the same fusion, and that's why it's classified as a DFSP, although it doesn't share the same nomenclature. It's considered a juvenile variant of DFSP, as in it usually occurs in pediatric patients. So FISH for PDGFB can confirm the diagnosis of DSFP in difficult or fibrosarcomatous cases where there is CD34 loss. We have a couple of differential diagnoses for DFSP. As we know, our classic DFSP, storiform pattern, infiltrating dermis and subcutis in the honeycomb pattern, positivity for CD34 and negativity for factor 13A, fibrosarcomatous DFSP, more of a herringbone pattern, and there is CD34 loss, so molecular pathology may be useful in such cases. And then we have dermatofibroma. It is more well circumscribed and it has epidermal hyperplasia, collagen trapping, and foamy cells. CD34 is negative, but factor 13A is positive. And of course, neurofibroma is positive for S100. Solitary fibrous tumor gives a patternless staghorn vessels and well circumscribed, and we know that it's positive for STAT6 if we want to differentiate. Myofibrosarcoma, it gives more of a fascicular eosinophilic spindle cells morphology. It's positive for SMA and Desmin if we want to differentiate. And finally, melanoma, the spindle cell type, it contains a typical pigmented spindle cells and junctional activity, and it is positive for S100, HMB45, and melon A. Here are some of the diagnostic pitfalls of diagnosing DFSP. So we can receive a small and superficial biopsy. So one of the biggest risks for a pathologist is to receive a small and superficial biopsy of a DFSP without the clinical information that it is a larger indurated plaque-like lesion. In such cases, the pathologist may only see a few extra spindle cells in the dermis and mistake the lesion itself for a scar, neurofibroma, or dermatofibroma. And another pitfall is recurrent lesions, where the history of prior biopsy is not provided. In such case, there's often actual scar from prior biopsy mixed up with recurrent tumor, and the lesion may be misdiagnosed as simply fibrosis. There can be an overlap with cellular dermatofibroma, which requires low power assessment. So we can differentiate it by morphology. DFSP is more infiltrative and there's no epidermal hypoplasia. Dermatofibroma is well circumscribed. There is epidermal hypoplasia and collagen trapping. The IHC for dermatofibroma CD34 is negative, and there is SMA focally positive. With CD34 positive perineurioma, it can mimic DFSP, but we can always use EMA and Claudin-1 to exclude that. If you see the morphology is similar to DFSP, but there is loss of CD34, you can consider the fibrosarcomatous transformation of DSFP or DFSP-FS, and you can use FISH to help differentiate. So all in all, the keys to remember for a diagnosis of DSFP is firstly, morphology. You can see a tight storiform architecture and uniform spindle cell morphology, a diffusely infiltrative growth with a honeycomb pattern. Honeycomb is important in the subcutaneous fat. Strong expression of CD34. And in cases of fibrosarcomatous DFSP, it may be more fascicular, herringbone architecture with increased mitotic activity. Our desirable criteria is detection of the COL1A1 PDGFB gene fusion. We'll talk a little about the treatment itself. So first, they can use the wide local excision. The recommended margin for wide local excision is more than or equal to 2 to 3 centimeters of normal tissue. But for wide local excision, the local recurrence rate is high, up to 20 to 30%, and even higher with narrow margins. And so that is why modified Moss microscopic surgery is the preferred or gold standard of treatment. It uses horizontal sectioning for complete margin control, and the recurrence rate is as little as less than 1%, and it is best for difficult sites such as head, neck, or tissue sparing sites. And we'll take a little look at the Moss micrographic surgery because I didn't know what it was before, but from this lesson, I've learned about it. So usually skin cancers have roots that extend beyond the visible tumor. And for the Moss surgery, they will remove the visible tumor first, and then they section the tumor in a way that they number the lesion carefully so they know which sections they take. And then they send it to a path lab, and they will process the tissue, and then pathologists will take a look at it to see if there is positive tumor margin. And if there is positive tumor margin for that section, they will resect that tumor again. And so this process continues until the pathologist does not see any more tumor in the resected margins. So simply, that is the Moss micrographic surgery, and that is why it has a lower recurrence rate. We'll talk a little about targeted therapy, imatinib mesylate. So it is used for unresectable, recurrent, or metastatic DFSP. Is usually used as neoadjuvant to shrink the tumor for surgery, and especially helpful for tumors that are positive in COL1A1, PDGFB in fish. Unfortunately, this is not as effective in metastatic fibrosarcomatous DFSP. For radiotherapy, the role remains uncertain in literature, but it could be used as an adjuvant option because DFSP is considered radiosensitive. And it's used in case where there is positive margin and further surgery is not feasible, or it is a large or unresectable or recurrent lesion. For the prognosis of DFSP, metastasis is rare, only around 2 to 5%. It's usually hematogenous and often to the lungs. And it's more likely to metastasize in DFSFP, FS, so fibrosarcomatous transformation. I think the metastasis is up to 10 to 15% with fibrosarcomatous and for long-standing recurrent tumor. Prognostic factors for poor outcome includes increased age, tumor size is over 5 centimeter, head or neck location, high mitotic index, p53 mutation and overexpression, or fibrosarcomatous transformation. Follow-up recommendation after surgery is every 6 months for the first 3 years, then annually for life, focusing on the surgical scar for local recurrence. And chest X-ray is done only if there's suspicion of metastasis. And this is my reference. I read the 2 articles that Dr. Bakocha sent me, and I also correlate that with the WHO Blue Book and pathology outlines. Thank you for your attention, everyone.
Really excellent presentation. So I have one question. So I've never seen something that I would classify as a myxoid DFSP, but I'm wondering if that would ever be confused with a low-grade fibromyxoid sarcoma, which also tends to be sometimes a trunk-like lesion that's deep dermal or fairly superficial fascial-based type of lesion. It doesn't have, I think, the infiltrative, honeycomb fat pattern, but certainly has a fairly low-grade spindle cell appearance. Did that ever enter the differential?
Yeah, I've never seen one either, Lewis, but you're absolutely right. I think it's so rare that I would imagine the literature on it is somewhat mixed up and unreliable. And maybe some of the things that were reported as myxoid DFSP actually were one of those other tumors you mentioned. So yeah, I would definitely put a hard stop if I saw any extensive myxoid change and say, is there any way I'm arriving at the wrong diagnosis here?
Yeah. I mean, they
The
obviously
cases
would
I've
have very
seen have
different.
not had any of that.
Yeah, they obviously would have very different genetics and very different immunohistochemical features, but
Mhm.
morphologically, I think they might be mixed up.
Mhm.
And I do remember when I was doing sort of general practice sorts of stuff that very often you would see cellular dermatofibromas that would be beginning to have that sort of fat infiltrative process at the base, and you kind of wonder, well, is this an early DFSP, or is this we're just going to call this a dermatofibroma?
Right.
Um,
Yeah, I
how,
wonder if I'm going to try to show you a picture. That question comes up a lot, but I haven't had good luck showing my picture. But let me see if I can get it to focus. Um,
uh,
no luck, huh? Okay. The camera has a mind of its own. Well, here, I'll tell you. Um, the DFSP will, or dermatofibroma can also involve the subcutis along with DFSP. When dermatofibroma does, you often have kind of a stellate or ray-like pattern of fibrous tissue and tumor extending into the fat. And you have the honeycomb appearance in between the rays. So just seeing that honeycomb, it can be very confusing for exactly the reasons you mentioned. Whereas when a DFSP goes down into the subcutis, it tends to go, flat and extensively surround the fat. So I always look for that ray-like pattern, almost like a target coming from the center of the DF going down if I'm considering a DF that's involving the subcutis versus a DFSP. One additional thing that is, and I, by the way, Harper, you did a fantastic job on that. You emphasize all the points I would make. Mainly the importance of the clinical pathologic correlation. I always worry about small biopsies where I don't have the full history, and so that's extremely important. The other thing that I've noticed about the cases I've seen is often the patients have had them for years, and because they're so slow growing, they don't go to seek medical attention, and then by the time you get the biopsy, the lesion is 10 centimeters across, huge, and requires a really extensive excision.
I used to just
Another,
think what was the wintertime effect, where you keep your clothes on in the winter, and then it gets
yeah,
warm, and you take off your long johns and your heavy coats, and you go, oh, what's this?
yeah. Another couple of diagnostic tips. One is a CD34 is very useful when it's positive. It's a red flag if it's negative, because almost every regular garden variety DFSP is positive. So if I always do it, but what I'm looking for is for it not to stain. It's like a red flag. It's saying stop. Either this is sarcomatous transformation, fibrosarcomatous transformation, or this is something else. But it should be strongly CD34 positive. The other helpful thing that's kind of old school microscopy is that if you look in the center of, often the differential diagnosis that is most frequent is cellular dermatofibroma versus DFSP. And a little trick is the old polarizing lenses, because if you look in the tumor of a dermatofibroma, you'll find, and I believe Harper mentioned this, you'll find entrapped collagen, coarse collagen, and it will polarize. Whereas if you look at a DFSP in the center of the tumor with your polarizing lenses, you're just not going to see anything polarizing. It doesn't work at the very edge of the tumor because you may start to see, adjacent dermal collagen. So it's not useful there, but I've used it a number of times when I've considered that.
Just one quick comment on that. Sometimes polarizing lenses may be very expensive if you have to buy the fitted ones for your particular microscope.
Right.
But I, for many years, got along very, very well with just a couple of very cheap plastic polarizing pieces of plastic, essentially, that I put one on top of the slide and one over the light source. Even you can go out and buy a very cheap set of sunglasses that have polarizing lenses and just take the lens out and use that quite adequately in that circumstance, and it will serve that function. So it doesn't have to be a $500 polarizing piece of equipment from the microscope company.
Yeah, that's great. They have to be the designer sunglasses that are large enough so that let's see.
Oh,
A
I saw
couple other
one
things.
other thing, Luke. Let me just ask you. I while we were talking, I took the liberty of looking at ImmunoQuery, which my department provides a nice subscription to. Just with that, some of those differential considerations in there. And one of the antibodies that came up that Harper did not mention was HMGA2 as being a nice differentiator between dermatofibroma and dermatofibrosarcoma protuberans. Did you ever use that, or?
I have never used that or worked in a lab that had it. So
Okay.
yeah, I don't know about that.
It's a send out for us, but we do use it sometimes in GYN pathology when we're looking at some of the soft tissue tumors in the vulva and vaginal area.
I see. Okay. Okay, yeah. I mean, one thing on the immuno point, I made the point earlier about looking for it to be negative. Just that bears emphasis that don't rely on a positive stain to make the diagnosis, because so many things in the differential diagnosis, from spindle cell lipoma to neurofibroma, are going to be positive for CD34 as well as other spindle things. So that's not like some tumors where, positive stain and that's what it is. So let's see, another thing I might talk about a little bit. Does anybody have any questions about Mohs surgery? Has anyone else heard of it, or this was new for you, Harper, to learn about Mohs surgery?
Yeah, I've never heard of it before, ever.
Okay. It's very resource intensive, and so it might be hard to get it in, because it involves a lot of technologist time and frozen sections and that sort of thing. So it might be difficult in a under-resourced area of the world where the first order treatment would simply be a wide local excision. And the reason they recommend wide is because it's so difficult to define the clinical edges of the tumor. But Mohs is extremely helpful in this type of case, as well as other types of tumors. And I just wanted to mention that one modification that some people use is what they call slow Mohs, because it's very difficult with a large tumor to get good frozen sections of a large margin, especially DFSP will often be very large. So they will sometimes process it the same way you would do the frozen sections for Mohs, but submit everything for permanent section and just rush the slides out the next day, and then do their stages. Instead of the same day, they would do one stage one day and another stage the next day and another stage the day after that, simply because it's much less expensive and less prone to error than actual Mohs frozen section. Yeah.
That's probably particularly valuable because you're oftentimes dealing down in the fatty tissues, which would be much harder to get reliable frozen sections on.
Right. Yeah.
Yeah.
Yeah. And if you have one take-home message, and I think Harper said it well, the most important thing with this tumor is to get it all out the first time.
That's true of so many things.
That's true, but this one, once it recurs in a scar, and then you're trying to get around that, and it's just really, really tough because it often isn't recognized clinically for a long time either, for the same reason it wasn't recognized the first time. It looks like a scar. So when it recurs in and around the scar, it just looks like scar, and there's a tendency not to biopsy and recognize it.
I think there are a number of other soft tissue tumors that are kind of like this in that sort of insidious fingers of growth into the surrounding tissues. Even some of the high-grade sarcomas, undifferentiated pleomorphic sarcoma and things like that can have those little small extensions that are why they ask for, 2 and 3 centimeter margins. Because even with that, you oftentimes find that you have funny looking cells at the margins of excision.
Yeah.
The risk of recurrence is there. So understanding the biology of these diseases, really has to guide the therapy. And oftentimes your surgical colleagues may not fully understand that biology unless you can tell them and teach them about those things so that they get that concept in their mind that the pattern of spread is insidious and not grossly visible when they're operating.
Any other comments or questions from anyone? You did a really nice job, Harper. It was very comprehensive, and I learned from it too.
Thank you, Doctor.
I've never seen a granular cell DFSP and didn't know it existed.
Yeah, no, that's true. I think that's why we enjoy these. I enjoy these because I learn things from your presentations, and we get some amazing things going. Obviously, there's so much in dermatopathology that we can't cover all of those things in these mentoring sessions. And even in the Derm module that we have on our course listings and so forth, really just covers the high points, the major diagnoses that you should know. Dermatopathology is just an incredibly rich domain of things to learn, that it is a lifetime pursuit. So you'll still be learning when you're at Luke's stage in life. And
there's so much information about a tumor like this. When I was learning, and still the thing I try to keep in mind is probably the most important thing when you approach a diagnosis or an entity is to construct the broadest possible differential diagnosis you can at the very beginning. Because if you don't think of it first, you're more likely to miss it. And so your slides, Harper, where you went over the differential diagnosis, neurofibroma, dermatofibroma, spindle cell lipoma, melanoma, all those things like you did, solitary fibrous tumor, lay those out as extensively as you can and sort of brainstorm to exhaustion. And then you can narrow it down from there. But if you somehow miss an entity at the very beginning and go down the wrong pathway, it's a very common way to get tied up and end up with the wrong diagnosis. And sometimes when we see a pattern like a story-form pattern like that, it's so distinctive, you just jump on that. Story-form, it's got to be a DFSP. But think, well, what else could it be? And I think that's always a good sort of I think I call it mindful diagnosis, being in the moment with your diagnosis.
And actually, that's one of the advantages of having digital teaching sets is that you can see a broad spectrum of a given entity without having to examine it, be in a very, very high volume place. You can see a library of things. And I think some of the studies of diagnostic error indicate that very often the reason that that occurs is because we have a very narrow vision of what an entity is, and we don't see the many variants of a disease. And so it may be a common disorder, but an uncommon presentation or variation that we just haven't encountered.
Yeah.
And so you've got to have both of those kinds of experiences, a really broad thought process about the other possibilities, as well as the appreciation that a given entity can have quite a broad spectrum of presentation and appearances.
Right.
And
And in DermPath, it's probably true in other areas as well, but there's actually a book that Bernie Ackerman wrote called The Lives of Lesions to indicate that the same lesion can have different appearances when it's new, when it's mature, and when it's aging or involuting. So that's another thing that makes our careers challenging, but also very, very interesting.
yeah.
All right. Well, good luck to everybody.
Any other questions before we wrap up? All right. Well, I don't hear that,
Right.
and so we're planning for at least one more session on skin stuff, and I believe Jin Yen, you are the one who's going to do the case for next time. Is that?
Yeah, evening
Yeah.
section. Yeah.
Yeah. Okay. Very good. So we'll be all set for 2 weeks from today.
Okay. Now, Jen Yen, are you going to do that with Dr. Bui?
Yeah, I already
Okay.
got the interesting case from Dr. Bui. Thank
Okay,
you
great.
so much. Yeah.
Sure.
All
Okay.
right. Well, thanks,
Bye-bye,
everyone.
everybody.
Bye.
Thank you, doctor.
Bye.
Thank you.
Thank you.